Now next up, we're going to talk about myocardial infarction complications. Now we've already discussed a lot of this info when we went through the evolution of myocardial infarction, but it never hurts to hear some of this again. Notice how these complications are listed in chronological order of expected occurrence after a myocardial infarction. And this can be incredibly important to help you eliminate answer choices on your test, as well as take care of real patients. Thankfully, many of the more severe complications rarely take place anymore due to prompt and aggressive treatment of MIs. And this includes things like stent placement, as well as appropriate use of anticoagulants and antiplatelet agents. Now first off, we want to talk about cardiac arrhythmias. Patients are at highest risk for cardiac arrhythmias 24 to 48 hours after an MI. Now, hypoxia here disrupts the pumps that maintain normal ion concentration within cardiac myocytes, as well as the extracellular environment. Disruption in extracellular potassium, as well as intracellular sodium and calcium, can start dangerous reentrant circuits, which can quickly kill your patient. There's also the risk that we've directly infarcted some part of the conduction system. All in all, this can result in depolarization abnormalities, which can result in anything from ectopic beats to fatal ventricular arrhythmias. Now next up, we have post-infarction fibrinous pericarditis, and this occurs 1 to 3 days post-MI. Now what happens here is the neutrophils, as well as fibrinous exudate that are a result of the myocardial infarction, end up extending from the necrotic subendocardial muscle layer into the pericardial cavity. Now remember that normally the pericardial cavity only has a tiny amount of ultrafiltrate to lubricate the visceral and parietal epicardial layers facing each other. So how will you determine that the patient has pericarditis? Well, the patient might describe sharp pleuritic pain that is alleviated by sitting up and leaning forward. On auscultation, you could hear a friction rub, and on the ECG, you may see widespread ST elevations and PR depressions. And all of this is due to the inflammation within the epicardium, and you can see an example of this here. Now our next complication here is papillary muscle rupture. Now when cardiac muscle is dying, you have more to worry about than just the ventricular wall. And here you can see an image of a papillary muscle that took a serious blow and died. Now with that said, which papillary muscle is most susceptible to ischemic injury and necrosis? There you go, that's going to be the posterior medial papillary muscle. Now unlike the other papillary muscles, the posterior medial papillary muscle only has one blood supply, and that's coming from the posterior descending artery, or the PDA, which comes off the right coronary artery. Now, the posterior medial papillary muscle attaches to the mitral valve, and if this ruptures, as you can see here, you will not be able to pull the valve via the chordae tendineae. This will lead to the acute onset of new mitral regurg. So in this scenario, you want to watch out for someone that is 2 to 7 days after a recent MI with the new onset of a systolic murmur. And in this scenario, this new onset regurg can be quite severe and present with acute pulmonary edema and florid heart failure. Now our next complication is intraventricular septal rupture, and this occurs when there's necrosis of the intraventricular septum, which leads to a new communication between the left and right ventricles, as you can see here. Now this creates a VSD, and it usually occurs 3 to 5 days after the initial heart attack. And in this scenario, you want to be on the lookout for an acute, new, loud, holosystolic murmur heard best over the right sternal border. And just a quick reminder, what's the difference between holosystolic and pansystolic? There you go, nothing. They mean the same thing. Now, with this VSD, if you were to check right heart oxygen saturations, you would see an increase in the oxygenated blood from the left ventricle crossing through the VSD into the right heart. You would also see increased right heart pressures due to excess blood being transmitted from the left ventricle into the right ventricle through the VSD. Now next up, we have ventricular pseudoaneurysm formation. Now remember, pseudo means false and aneurysm means dilation. And these are called false aneurysms because there's only one layer within the wall of the aneurysm. Here, all the endocardium and myocardium died, and you need these to be intact to have a true aneurysm. So in this situation, the only thing holding this aneurysm together from completely exploding is the fibrous adhesions of the epicardium. Also in this situation, due to the missing myocardium, you're going to suspect decreased contractility and therefore a decreased cardiac output. Also, due to the mixture of fibrotic tissue as well as damaged muscle near the rupture site, you get the perfect situation to create a re-entry circuit and a potentially deadly arrhythmia. Also, within the pseudoaneurysm, blood can pool and form a thrombus. Now you want to be on the lookout for all this 3 to 14 days after the MI. Now next up, we have ventricular free wall rupture. And here in our image, our black arrow is pointing to a complete left ventricular free wall rupture. This usually occurs 5 to 14 days after transmural ST segment elevation myocardial infarction. Now in these situations, patients typically develop acute cardiac tamponade, and this usually leads to sudden death unless they're taken to the OR immediately. Often, even if it's caught in time to go to the OR, there's not much that can be done to save these patients. Now next up, we have a true ventricular aneurysm. Now true aneurysm occurs because of a transmural fibrotic scar over the ventricular wall that ends up bulging out, as you can see here. Now the scar tissue cannot contract like a normal myocardium, and this is why you actually see the ballooning here. It takes a long time for healing to complete this process. This is why you'd expect to see this 2 weeks to several months after the MI. And as you would imagine, this enlarged area with fibrosis will not be able to contract when the surrounding myocytes do contract, and this will lead to abnormal wall motion called dyskinesia. Now next up, we have Dressler syndrome. Now this is an autoimmune response against cardiac antigens that takes place after an MI or after cardiac surgery. Now it takes a couple weeks for this to develop because the immune system has to create antibodies to cardiac antigens here. Now the end result is fibrinous pericarditis, and you can see an example of this here. And in this scenario, you can hear a significant pericardial friction rub as well as develop a pericardial effusion. Now our last complication here is left ventricular failure as well as pulmonary edema. Anytime you lose cardiac myocytes after a left ventricular infarction, you're losing cells that are going to help push blood out of the left ventricle. Since these cells have been lost, you're going to get decreased contractility, which will result in a decreased cardiac output, which will then lead to blood backing up from the left ventricle into the left atrium and then into the lungs, resulting in pulmonary edema. And in this scenario, what would you expect to see on physical exam? There you go, maybe crackles at the bilateral bases, or the patient might report orthopnea or paroxysmal nocturnal dyspnea, and on chest x-ray, you might even see bilateral pleural effusions. Alright, well that's going to wrap up myocardial infarction complications. See you in the next video.